Good evening, ladies and gentlemen. Welcome to Guess the Paper series from Alan Next. And here we're going to talk about ophthalmology and, as usual, guiding you through the minefields of ophthalmology, your friendly neighborhood ophthalmologist, your student Sashwat. Now, ladies and gentlemen, we call it Guess the Paper, but actually the paper cannot be guessed. So, what we are going to do, at least what I'm going to do in my little presentation, and we'll make it short and sweet, like mostly. Ophthalmology is mostly short and sweet. No? So what we're going to do is to revise some of the questions that I've asked in the last few years. So PYQs, we'll do a few quick PYQs of the last few years, last 3 to 4 years actually. And then I'll go guide you through some of the most important signs in ophthalmology, which is particularly the lines, the dots, the spots, the rings, things like that. And some ophthalmic procedures, some photographs of the most important instruments, which you may or may not remember, but are present in the app, Alan app, and in my live classes. Those of you who've had the good fortune, shall I say, to watch them. So here we start with ophthalmology and with my trademark Eyes of the Mona Lisa, with which I'm completely and totally in love with. We start with our Guess the Paper series in ophthalmology. And let's look at this question. A 60-year-old child is taken up for cataract surgery. What should the parameter to consider as he grows older? What is that? Hyperopic shift, myopic shift, see increase in lens capsule diameter, and increase in size of the eyeball. Now remember the answer here, see what is happening here is basically there's a cataract surgery performed for a child for congenital cataracts. Okay, he's a 6-year-old. So the problem here is actually the eyeball is growing, the size of the eyeball is growing, okay, because it's a child, so the eyeball will grow. So that is not the answer, increase in size, which is the correct. I mean, this is also correct. But what is the parameter to consider as it grows older for cataract surgery is not that the increase in size of the eye, but what does it lead to? It leads to this problem called myopic shift. Okay, so you see here, this is called the myopic shift. This is the B, myopic shift is the correct answer. Why is that? Let's look at that. So what happens here is you can see here that we have placed an intraocular lens in a child. And how do I know it's a pediatric cataract? Because if you see just behind the IOL, you see this ring here that I can trace out with my pen. This is the size of the posterior capsular rhexis. Okay, this is the posterior capsular rhexis here, which you perform in children so that they do not have a secondary cataract. Now, see what is happening here in this problem is this thing, this myopic shift. Let me talk about that. See, myopic shift occurs because the child is growing. The child is growing. So, when you place the intraocular lens during cataract surgery, you have calculated the IOL power for a certain axial length like this. So, you calculate the IOL power, you have placed the IOL here, and the rays focus on the retina the next day perfectly. Okay, so this is fine. But you see, as the years go by, the child's eye is expanding, okay, from 17 millimeter, 18 millimeter, 19, 20 millimeter. So what will happen? After some years, maybe a couple of years, since the eyeball is growing, the retina will come here. The retina will come there, but the rays are still focusing on the spot that was designated from there, which is here, is it not? So this child becomes myopic. So as the child becomes older, the IOL power, remember, is not able to keep up with the growth of the eyeball. So this patient has got myopia. So this child develops myopia. That is a big problem for children because as they grow older, we find that they cannot see very clearly because of myopia. We have to give them glasses. This problem does not happen in adults because in adults, the eyeball has attained its natural growth and cannot grow further. So there is no myopic shift in adults, but because of the growth of the eyeball in children, the problem is a myopic shift. Okay, so please remember, both the answers are correct. There's increase in lens capsule diameter is not important because there's no lens here. We've already done cataract surgery. So, and there's no hyperopic shift obviously, but there is a myopic shift and increase size. So you might say, why is this not the answer? Well, it is also correct, but you see, you can have both correct and the answer will be 1, which is what? The parameter to consider as he grows older is the myopic shift, which we are considering because we'll have to give him glasses for myopia, isn't it? So that is the trick. So please remember, you can have 2 correct answers and yet we'll take 1 only. Next, a simple one. A child presents with a pupillary reflex, which you can see from birth, like this whitish reflex. Remember, the normal red glow is normal. Patient has strabismus also, means there's a squint also. On CT scan, a calcification in DME. We've given you so many clues that it's impossible to get the answer wrong. And a cauliflower-like growth is seen on indirect ophthalmoscopy. what could be diagnosis. And ladies and gentlemen, you do not have to read the choices also. Straight away, you have to look straight away for choice number B, which is retinoblastoma. There are so many clues. First, we get the leukocoria, the white pupil reflex. Second, he had squint also, which is the second commonest presentation of retinoblastoma after leukocoria is squint. Third, you see calcification, and that is the most important sign because it is the calcification which appears to us as the white colored pupil. The leukocoria is because of the calcification, is not. And on fourth, you can see a cauliflower-like growth, which is the typical look of retinoblastoma on indirect ophthalmoscopy. So the answer is retinoblastoma. So please remember multiple signs of leukocoria, which you can see in the first picture. You see the white pupil, and that white pupil appears as the calcification. But remember, you can have other differential diagnosis of white pupil children also, is it not? So see, this child also has a white pupil, but this is not retinoblastoma. It is congenital cataract. So kindly remember the three most common differential diagnoses of white pupils. And this is another child who also has leukocoria, but this is Coats disease. Okay, Coats disease, please remember, is the second commonest cause of leukocoria in children after retinoblastoma. So once you've ruled out retinoblastoma, number 2 is Coats, and then we have to think of a congenital cataract, which can also produce a white pupil. So these are the three important different diagnoses of leukocoria, and I dare say that all of you have got this right. A middle-aged patient presents with bilateral ptosis, lids are down, which varies diurnally, which means that the ptosis increases or decreases according to the time of the day and becomes more symptomatic in the evening, dear me. So you've got the answer, as the ptosis basically worsens in the evening, is it not? And what does that tell you? It's called lid fatigability, or we call it fatigable ptosis, or we also call it at fluctuating ptosis, which increases in the evening and improves with the ice pack test. Again, ladies and gentlemen, you don't have to look at the choice also, you have to just look for the answer, which is C for Calcutta here. Myasthenia gravis, which you know, the myasthenia gravis has two important groups of people, the young ladies and old men, so middle-aged patient with bilateral ptosis. Ptosis is usually bilateral, could be unilateral also, and is the first presentation of ocular myasthenia because LPS is the first muscle to get damaged in myasthenia. Varies diurnally. This is the clue. This fluctuation with worsening of the ptosis in the evening is very typically seen in myasthenia, and improves the ice pack test because when you put an ice pack, remember, as you cool the neuromuscular junction, it improves the electrical transmission. Okay, so by cooling the neuromuscular, so when you put an ice pack on the lids, closed lids for about 2 minutes, you can see that. Look at the ptosis here, and we put it for about 2 minutes, and immediately following that, you can see the ptosis improves immediately. A resolution of more than 2 millimeter means that the ptosis is improved, and this is the diagnostic test. This is almost as equally effective as the tensilon test. In fact, this is more useful to us because this is more safe. Tensilon is a little unsafe. We cannot always do tensilon test in a bedside, but we can always perform the ice pack test. The answer is myasthenia. I hope you got this correct. See, remember, these are all questions taken from the last few years of PYQs, previously asked questions. The test shown in the image, so let's look at the test. First picture is just 2 eyes. Second, we have put some kind of occluder there. And third, we've taken it off again. So we see the difference in, as we put an occluder means occluding the eye, the position of the eye has gone inwards, okay? That's gone inwards. So this is esotropia. Why has it gone inwards? Because it takes a normal position. When the eyes are closed, that means the eye is normal resting position. In the resting position, the eye goes to normal position, which in this case is moved inwards, esotropia. So this is a test for squint. But as we take the cover off, we find the eyeball comes to its normal position, which looks straight to the right. And the answer here, ladies and gentlemen, is choice A, the cover-uncover test, which picks up the phoreas. Remember, phoreas are squints which cannot be seen directly because they're latent, they're hidden. So when you close the eye with an occluder or a cover like this, so what do? You break the fusion. The fusion keeps the two eyes together. So in normal gaze, in a phorea, eyes are parallel because the fusion has kept the two eyes together. The minute you put the cover on, it breaks the fusion, eye moves to normal position, which is an esotropia here in this particular picture. So it's broken the fusion. And as you remove the cover, immediately the eyeball moves back to its normal position to look at the light. So this is how the cover-uncover test, it is performed like this and picks up. So what you do when you cover this eye, So you cannot see what's happening behind the eye. It's not behind the cover because it is opaque. When you take off the cover, look at the position of the eye. If it is straight, if it looks straight at you, it means there is no squint. But if it moves from in to out, it moves from out to in. If it moves from in to outwards, as you move the cover, it means he has an esotropia. If it moves out to in, it means he has an exotropia. If there is no movement, there is no squint at all. Okay, so this is the cover uncover test, which you must have guessed by the way we have framed the question. Very well. Next question. So, ladies and gentlemen, we are basically doing some PYQs, and then we'll go to some other things which are a conglomerate of all the things that we expect in your paper this time. A firm painless nodule, you can see it here on the upper lid of a patient of 30 years of age with the prominence away from the lid margin is most likely to be, and those of you have seen these pictures repeatedly that I have flashed them, you recognize them. It's not a sty, it's not a squamous cell carcinoma in a 30-year-old patient. It's unlikely, and it is indeed a chalazion. It's a chalazion, which is a chronic inflammatory granuloma of the meibomian glands, is it not? So this is a painless nodule, as I mentioned here. See, why it's not a sty? Because a sty would have been painful. So this is a painless. This is neither the internal nodule, again very, very painful. So this is a painless nodule which gives you an upper lid, typical position of a chalazion, which is a chronic inflammatory granuloma of the meibomian glands. Okay, remember chalazion, and the question that we like to ask you, ladies and gentlemen, you have to be careful about this, that when we ask chalazion, remember an important differential diagnosis happens to be a sebaceous cell carcinoma. Now, if the question had been, say, a 60-year-old lady, sebaceous carcinoma occurs women, mostly older women, and a similar form painless nodule, which looks a bit like this, and which is often mistaken for a chalazion, okay, is actually a very dangerous thing called a sebaceous cell carcinoma. And you can see it here. Look at that. This is an old gentleman, as you can see, and this is looks just like a chalazion, but it's not a chalazion. It's not a chalazion. It's actually a sebaceous cell carcinoma, which can be extremely malignant, and very dangerous. So remember, a differential diagnosis of a recurrent chalazion in older women is likely to be a sebaceous cell carcinoma. After all, remember, chalazion is a chronic inflammatory granuloma of meibomian glands, and the meibomian glands are nothing but modified sebaceous glands. So a sebaceous cell carcinoma can very well attack the meibomian glands. Okay, very well. A child with low socioeconomic background, that gives you a hint of some deficiency. With foaming white spots and dear me, this is so obvious on both temporal conjunctiva, not one but both. What could the vitamin deficiency be? And you know, these are classically bitoid spots, and bitoid spots are a very specific sign of vitamin A deficiency. So it is indeed choice A, vitamin A deficiency. Bitoid spots are very specifically one shot of vitamin A injection, and bitoid spots disappear in about 2 weeks. They have been literally melt away, so to say, like snow in exposed to hot sun. So this is bitoid spots. So we know by the look that's a vitamin A deficiency. Okay. So the answer is a very simple one of the simple questions, but you do need to have some simple questions. Remember, this is the guess the paper, and your paper does have some simple questions and mixed up with a few difficult ones and mixed up with some middle difficulty questions. Then a 3-year-old boy presents to you with itching and red eyes, which is more in summer. Remember, summer madness, not summer of 62, summer madness. And this is also ropey discharge from the eyes. There's a lot of clues here. What is the probable diagnosis? If you look at the pictures, you see some giant flat top things here, and this, you know, we call them as giant papillary conjunctivitis. Remember, these are papillae, but remember, the answer is not GPC because the size of the papillae tells us. Remember, we call them giant papillae. How do you know a papillae first? Because they are flat topped, they're reddish, they're velvety, and you know, papillae are seen in allergy conditions. When they are more than 1 millimeter in size, we call them giant papillae. The normal papillae are less than 0.3 millimeter in size. Okay, when they're more than 1, we call them giant papillae. So it could be GPC, it could also be spring catarrh. Both of them have giant papillae, remember, and by looking at the giant papillae, you cannot make out whether it is due to GPC or whether because of spring catarrh. But the answer here is spring catarrh, simply because of red and itching eyes, which is more in summer in a small child. Okay, remember, they are seen in children, particularly boys, particularly in summer, where they start itching their eyes. So giant papillae, why it is not the answer? Because giant papillae, even though they look the same, this is GPC, but this is seen in contact lens wear. Please remember the kind of findings that we find here, the big papillae, giant papillae, more than 1 millimeter papillae, can be seen in both spring catarrh as well as GPC. But GPC will see in a contact lens wear history, and spring catarrh will be seen in a young boy who complains of itching in hot weathers. So the finding is not specific for both of them. They are similar in both GPC as well as spring catarrh, but the history tells us it's spring catarrh. But be careful when you have a contact lens wear, the diagnosis will become GPC. Mark the correct disease for the given, and this is a disease which image has been repeated 100 times in the last few years. You all know the famous dendritic ulcer. This is the viral keratitis. Remember the other question could be here. This is the dendritic ulcer because they look like the branches of a tree, which means dendrites. Also, it could be a geographic ulcer because remember, dendrogeographic ulcer. And the second question, what is the stain we've used here? Is the fluorescein stain. And third question often asked now is what is the blue filter we have used in the slit lamp? Is the cobalt blue filter, the cobalt blue filter. Okay, so the answer is viral keratitis. Multiple questions. What kind of filter are you using? The cobalt blue. What kind of stain, fluorescein dye we are using? Dendritic ulcer or viral keratitis is the correct answer. A one-eyed person got hit by a punch on the only eye. Dear me, that's really sad. Following which he experienced diplopia. What can the cause of this be? Remember, so it's not binocular diplopia. Remember, when you have both eyes, the double vision with both eyes causes binocular diplopia. And I've told you umpteen times that the first and the most common cause of binocular diplopia is squint. So this is a uniocular diplopia. But why is he having it? Because you can see here, look at that, there is a tearing of the iris away from the insertion to the ciliary body, which is called as iridodialysis. So the answer is iridodialysis. And why is he having diplopia? He's having monocular diplopia because now he has almost two different pupils. One, the pupil which is here, the original pupil, which is becoming a D-shaped pupil. Another question in iridodialysis is the answer is iridodialysis, and this is the dialysis, and this also acts as a pupil, this also acts as a pupil. So since there are two light rays going through the, one through the normal pupil, other through the pseudo pupil, so to say, created by the iridodialysis, so the patient is having monocular diplopia. The answer you can see clearly, the D-shaped pupil, ladies and gentlemen. You can see the D-shaped pupil. You can see it here, and you can see. So these two are forming like a dual pupil, like a double kind of pupil. One ray passing through this, the other light passing through this, and that is why they have monocular diplopia. So remember, iridodialysis can lead to a monocular diplopia. The answer is iridodialysis here. Okay. Very well. Then a boy was hit by a cricket ball while playing, and next morning he presented with a headache, diplopia looking up, and in ophthalmos. Who is the following responsible for this? Fracture of the roof of the orbit, fracture of the floor of the orbit, a subdural hematoma, and intracranial hemorrhage. And all of you must have got this right. Is the fracture of the floor of the orbit, which is the most commonly fractured floor. This is called a blowout fracture, where the most commonly fractured wall of the orbit is the floor, isn't it? And how do I know? Because he has the triad of diplopia and looking up, because the inferior rectus got trapped in the fracture wall and is not allowing the eyeball to move up. And in ophthalmos is a well-known sign. Remember the classic DIE, okay? Diplopia, infraorbital anesthesia, in ophthalmos is a sign of blowout fracture. And you see this is what is happening. This eye is looking up, it is perfectly normal, but this eye is trying to look up, is not able to go up, because the inferior rectus muscle has got entrapped in the floor fracture. The floor of the orbit has fractured and trapped the inferior rectus muscle, so it's not able to contract or relax, and that is why the eyeball is not able to follow. That is why he has diplopia and looking upwards, and that was the hint, which is the fracture of the floor of the orbit, okay? Which is also, if you all remember, is the most common fracture of the wall, most common wall to fracture in orbit is the inferior wall. Next question, ladies and gentlemen, and this is a good question. I like this. Identify the step of cataract surgery given them. And see what you're doing is against the red glow, you are pulling some kind of a thing which in a shape of an envelope, and this is an IL aspirin incorrect, IL implant incorrect, hydrodissection incorrect. Is capsulorhexis. What you're doing is tearing the capsule in a single fluid motion like this. This we call a CCC. Isn't it? It is the best form of opening the anticapsule, which you have to do to remove the cataracts through the anterior capsule opening and implant dye in the capsular bag. This stands for a circular continuous capsulorhexis. Tearing the capsule in a single fluid motion like that is the capsulorhexis, which you can see here. See, this is how we're tearing the capsule. In a single fluid motion, we're tearing the capsule like this. So the capsule comes out in a single fluid motion. This is important for us to take the cataract out and to place the intraocular lens. Very well. Identify the image, and you can see this clearly is brown ring on top of the lens here. This brown ring is because we call it the Vossius ring. We'll discuss this again in a short while. The Vossius ring occurs when you get hit in the eye. It's a trauma question. So this is what happens as you get hit in the eye. So the iris, it hits against the lens capsule. It is a lens capsule, and on the lens capsule creates a ring of pigment like this, which goes the Vossius ring. And you see this beautiful Vossius ring here that you see. This is a sign of old trauma as the iris touches the lens capsule and imprints its pupillary margin on top of the lens surface, anterior capsule. And this is the famous Vossius ring. You should all recognize this in the exam if it's asked. Next question is, where is a lesion located in the optic pathway, which can cause the given visual field defect? And you see here, we've got a field defect here. So both the temporals are gone, which means bitemporal hemianopia. You know, when the bitemporal hemianopia means that both the nasal fibers have to be damaged. You all know that the visual field damage always occurs due to opposite retinal fibers, not. So bitemporal means binasal damage, and binasal damage can take place in only one place, where the two nasal fibers come close together, which is the optic chiasm. Again, choice A. We all should have got this. It is optic chiasm. You can see here. See two nasal fibers in blue here. See, they come here like this, and they come here like this. And at the chiasm, the crossover, is it not? The crossover. So at the optic chiasm, if there's a very small lesion, it can compress the two nasal fibers and be leading to bitemporal hemianopia. And that is why this is a chiasmal lesion. And the most common chiasmal lesion to cause bitemporal hemianopia is the pituitary adenoma. We've all got this right. So answer here is optic chiasma, and the most common lesion to cause a chiasmal lesion to cause a bitemporal hemianopia, as you see here, is a pituitary adenoma. Which of the following is not seen in keratoconus? So let's look at the signs of keratoconus and see irregular astigmatism that is seen, correct? Remember, in keratoconus, because the surface of the cornea is not very regular, so light rays glance off here and there like this. Irregular is called irregular astigmatism. Munson's sign, yes, Munson's sign, you do see it. What is that? You hold the lid like this. Ask me to look down. As you look down, you will find the lower lid forms a cone or a notch or indentation of the lower lid on looking down. Is the Munson's sign. This is also seen. And scissoring reflex in retinoscopy is also seen. When you do retinoscopy, you will find the instead of retinoscope or going against or with the rule like this, it goes like this. Okay, look at that. This is the scissoring reflex that you see in retinoscopy, which is so typical, one of very early signs of keratoconus. The answer here is Habs trial, ladies and gentlemen. This is the answer. Habs trial it is, which is seen in congenital glaucoma. And you see, look at these parallel railway tracks here, typically appearing. And this is a rupture of Descemet's membrane because of raised intraocular pressure, stretching the Descemet's membrane and appearing as parallel tracks. This is a Habs trial. This is not seen in keratoconus. And you see here the Munson sign. We asked when look down, you can see what is happening to the lower lid. The lower lid forms almost triangle like a notch as it gets compressed and depressed by the cone here. So the answer here is Habs trial. Okay, so please be careful. Which of them is not seen? You have to be careful about these questions. Which of them is not seen? All of them are true except which of the most likely, least likely, most unlikely, least unlikely. Okay, so you have to get hold of these terminologies also. It's no point if you can't even understand the question, how will you write the answers? No, it's very, very important. So please, ladies and gentlemen, spend some time on reading the question, at least not once, but not twice, but thrice, I would say, read the question. Most of the time, the answers are given in the question itself. Very well. Which of the following is incorrect about the given condition? And what we see here is the triangular encroachment of the conjunctiva. So we all know by the multiple times that we have seen this condition, this is called as pterygium, is it not? Which means a bird's wing. Bird's wing. So is it what is incorrect here, right? So let's look at that. Is an elastoid degeneration of the conjunctiva is correct. It is an elastoid degeneration of the conjunctiva. Elastoid degeneration is a kind of pathological damage to the conjunctiva. Kinds of head, neck and body is also correct. This is the neck, this is the head and this is the body. And two types, progressive or regressive is also correct. One pterygium progresses, the other is there but does not progress, we call it regressive. And what is incorrect, which is what we want to know, is the simple excision can result in reduction of 95% of recurrence. Is incorrect. Remember, simple excision, the high rate of recurrence the recurrence is almost 70%, okay? And simple excision does not reduce in 95 recurrence at all. In fact, it causes a recurrence rate of very high, almost 70-75%. So this is incorrect. So what we do not do simple excision. What we do is excision with conjunctival autograft. So first you excise it, and from the other eye of the same patient, take out a little bit of conjunctiva and you stick it here either by tape or with glue or with sutures. So simple excision does have a very high recurrence, and so what we do is not an excision but excision with conjunctival autograft. And we can see here that after having taken out, you see this is the conjunctiva which is borrowed from the other eye of the patient, and that's why it's called autograft, and placed it here on the area of the excision so that there is no space for the pterygium to go back in. Okay, so this is the best treatment nowadays. A patient presents to squint in the right eye. Look at the picture as shown below. You can see the right eye, the cornea is moving up, and identify the nerve lesion. Is the oculomotor, trochlear, trigeminal or abducent? And remember, ladies and gentlemen, this is fourth nerve paralysis. Fourth nerve is the trochlear nerve palsy. Why? Because remember, fourth nerve palsy, superior oblique, SO4. You all remember the formula, LR6, SO4, R3, is it not? So the superior oblique is supplied by the fourth nerve, and when the fourth nerve is paralyzed, that's the trochlear paralyzed, superior oblique is paralyzed. And superior oblique is one of the depressors. It depresses the eyeball, is it not? So when that gets paralyzed, the eyeball moves up like that, is it not? So this is the diagnosis. You can see the right eye has moved up, and you can see in this case the left eye has moved up, because the two depressors of the eye, one of them is inferior rectus, second is superior oblique. They depress the eyeball. Any one of them gets paralyzed, the eyeball will move up. So that's why you see in this case, eyeball is again moved up. This is the superior oblique. Okay, remember, inferior rectus depresses in this position, which is the abducted eye, and superior oblique depresses in the adducted eye. So whenever you're suspecting a fourth nerve palsy, ask the patient to look inwards like this. Suppose right eye, ask the patient to look in, and as the eye moves in, ask the patient to look down, and instead of depressor is paralyzed, it will move up immediately, which you see here. Okay. So in the adducted gaze, if the eyeball moves up, it means the depressor superior oblique is paralyzed, which is the fourth nerve. And therefore, the answer is trochlear, the fourth nerve paralysis. Then, so the reason that was enough about questions. We've done enough questions here, and that was just a sample. Remember, this is, in a restaurant, you often have a kebab platter where you have a sample of various kinds of kebabs. So in this case, we have to sample. We've sampled some questions. Now I'm going to give you some very important numbers here. Okay. Remember, whenever we take a class, there are certain things we have to memorize. And I've mentioned here, this is the most important numbers that you remember. We call this the I numbers. So ladies and gentlemen, please take out your pens and start writing. What are the most important numbers that require in ophthalmology? The volume of the eye, 6 ml eyeball inside a 30 ml orbit. Axial length, normal axial length, 24 millimeters. High myopia is defined whenever the power goes beyond 6 diopters, which means the eyeball length of 26 millimeter. How? Because you know, or should know, that every 1 millimeter of extra length causes 3 diopters of myopia, is it not? So 6 diopter means 2 millimeter extra, which is more than 26 millimeter. For cornea, what we require, average thickness, you have to remember, 540 microns. Average, most of us, we have approximately 540 microns. Average power of the cornea is approximately 43 diopters. Remember, 43 for cornea, 19 for the lens, makes a 60 diopter eyeball. Contrary for LASIK, if you have less than 480 microns, remember, out of 540 less than 480, I'm so sorry, many of you want a LASIK for correction of a refractive error. I'm so sorry to tell you, if you have a thin cornea, less than 480, then we should not perform LASIK. Endothelial count, remember, norm count is between 2500 to 3000 cells per square millimeter, okay, endothelial count of the cornea. And critical density is less than 500 cells per square millimeter. Less than that, immediately you have corneal edema. So that can be asked in a different way. What is the minimum number of cells required for keeping the cornea clear? Is 500 cells. Then what about antechamber numbers? Average AC depth is about 3 millimeters, but remember you can have a shallow AC, you can have a deep AC. Critical angle is 46 degrees. Remember, this is sometimes asked because what is the critical angle? So you see, this is the cornea and this is the iris, okay? Now we cannot see the angle. Why we cannot see? This is the angle, iris and cornea. Why we cannot see the angle? Because of a property called total internal reflection. Okay, see, the light from the angle, it goes to the cornea and gets reflected back. Total internal reflection, it cannot go out, and that is why we cannot see the angle. We have to need a gonioscope. So we use a gonioscope, and that gonioscope increases the angle to more than 46 degrees. So remember, whenever you have the critical angle is more than 46 degrees, you can see the angle. Okay, so that is why gonioscopy. So please remember, sometimes we like to ask you, what is the critical angle of the eye? You have to remember 46 degrees. In aqueous humor, we require production rate approximately 2.5 microliters per minute. You have to memorize this particular figure. Intraocular pressure, normal intraocular between 10 to 21 millimeters of mercury. With more than 20 millimeters of mercury, we cause glaucoma. In the lens, we have to remember the normal refractive index at the center of the lens approximately 1.4, and refractive power of the lens is 19 diopters. Remember, 43 for cornea, 19 for the lens. The next thing is ciliary body. So what about the ciliary body? We knew two things. Pars plicator is the site of production of the aqueous humor. Pars plana is the site of intravitreal injection, which is approximately located 3.54 to 4 millimeters in a phakic eye posterior to the limbus. All these stuff you have to memorize. Vitreous volume is approximately 4 ml, and the highest amount of hyaluronic acid is present in the vitreous humor because to act as a shock absorber. Foveal diameter is 1.5 millimeter. You have to memorize this, with the same as optic disc diameter. So remember, optic disc diameter 1 ODD is 1.5 millimeter. So we can ask you what is 2 disc diameters. You should be able to calculate as 3 millimeters. If I ask you 3 disc diameters, you have to remember 4.5 millimeter. Okay, 1 disc diameter is 1.5. And the optic disc has 1.2 million axons. 1.2 has almost 1 million axons, and the normal cup disc ratio is 0.3 to 0.6. So anytime it goes more than 0.7, you start suspecting glaucoma. Okay, so ladies and gentlemen, these are the most important numbers that we require from you. You have to remember all of them. And then a quick recap of the various spots, the dots, the lines, okay, the spots, the dots, the lines, the rings that we have in ophthalmology. Quick revision which you have, and a quick revision of the number of instruments that you require in ophthalmology also. So all of you know, Bitot spots looks like foamy white secretion. This is the Bitot spots. Okay. Remember, Bitot spots are seen in vitamin A deficiency. And then another next spot is the Foster-Fuchs spot. Look at that. Foster-Fuchs, please do not confuse this with the Dehlen-Fuchs spots. Remember, Dehlen-Fuchs spots were seen, were nodules in the choroid in sympathetic ophthalmitis. This is Foster-Fuchs spot. This is different from Dehlen-Fuchs. What is that? Foster-Fuchs spot is, you see in high myopia, because of stretching of the eyeball, the blood vessels rupture and they cause bleeding. They cause bleeding or hemorrhage over the macula. This hemorrhagic spot over the macula in a pathological myopia is called Foster-Fuchs spots, not to be confused with Dehlen-Fuchs spots. Then some dots, the Horner-Trantas. Look at these whitish dots on the limbus here. These are Horner-Trantas dots, and they tell you that you have sphincter. These are collections of eosinophils, the sphincter. Arld's line. Remember, Arld's line is the white line fibrotic scar on the palpebral conjunctiva seen in trachoma. Not to be confused with the Arld's triangle, where the KPs get attached in the inferior triangle of the cornea, where the KPs get attached in anteuveitis. So Arld's line versus Arld's triangle. Okay, so all these are points of literal potential confusion. Then Patton's lines. Now, Patton's lines, remember we're talking about lines now, Arld's lines, so we have the Patton's lines. And Patton's lines are these folds, concentric folds around the optic disc, which you find in papilledema. We have just discussed this. Remember, papilledema is disc edema due to raised intracranial tension. So in papilloma, there is so much edema. What it causes these concentric folds on the surrounding retina. And these concentric folds on the retina is called as Patton's lines, which can be seen on these white dots, white arrows here, and they are seen in papilledema. Remember, we talk about lines now. Then the next is an important line called the coda-deuce line. Can you all see this line? Look at my pointer. This coda-deuce line is a line which is seen in a graft. You can see a corneal keratoplasty here. When you have it, tells you about a corneal transplant rejection. Okay, so whenever you have a transplant rejection, you get this white line at the junction of the rejected cornea. So this, you can see the corneal transplant is rejecting now. How do we know? Because you can see the corneal edema here. This is clear graft. At the junction of the clear and the edematous graft, you see this white line called the coda-deuce line is a sign of transplant rejection. Please remember, we're doing the lines now. Now we go to some spots here. With some dots, we now go to spots. The famous cherry red spot, which you see in CRAO, central retinal arterial occlusion. There's no doubt about that. This is possibly the most famous question in ophthalmology. Then the Stocker's line, we got a line here again, and the Stocker's line is a line at the head of a pterygium. Okay, you can see the white arrow here, and I've drawn it here also. This is a pigment, is an iron line, which is seen at the head of the advancing pterygium. This is called the Stocker's line. Okay, it's in the head of a advancing pterygium. So we're doing lines. Then some striae. They have two striae in ophthalmology. Remember, these are folds like this. These parallel railway tracks are seen in, you see it in Ophthalmos, also congenital glaucoma, also called as ophthalmos, because raised intraocular pressure, it ruptures the Descemet's membrane and causes these folds called Hab striae. This is not to be confused with the second striae in ophthalmology called Vogue striae, and these are these vertical folds in the corneal stroma which you see in keratoconus. Okay, please remember, you get the Vogue striae in keratoconus and the Hab striae in ophthalmos. So there are two striae in ophthalmology. The next are certain rings that we need to know. The famous KF ring. Look at the brown ring. This Kayser-Fleischer ring found in Wilson's disease. This is due to copper deposition on the Descemet's membrane. You can see it in the periphery of the cornea. However, this KF ring is not to be confused with the Fleischer's ring, which you see again under cobalt blue filter. You can see this ring that we've drawn here. This the Fleischer ring is seen in keratoconus. Okay, at the base of the cone, you see the Fleischer ring, which is an iron line. Remember, KF ring is copper, Fleischer ring is iron. KF ring is deposition on the Descemet's membrane, Fleischer ring is deposition on the epithelium, and this is copper and this is iron. This is keratoconus and that is Wilson's disease. So these are KF ring and Fleischer ring. The next ring is the Vossius ring, which we've discussed today already. The ring of pigment, which is a sign of trauma where the iris pupil hits the lens capsule and leaves a pigment around it. This is the Vossius ring. Then the next is Sommering's, remember, Sommering's ring, which you remember is a posterior capsular opacity after cataract surgery. When you have, there are two types of secondary cataract, also called a posterior capsular opacification. So one more famous is the Elschnick's pulse, we can see behind the eye here, but the less commonly is Sommering's ring also, which is a second type of a posterior capsular opacity, also called a secondary cataract. So we're doing various kinds of rings now. The next thing are the various dyes we have seen in ophthalmology. We have combined them all the things together. Remember, we're talking about 4 different dyes here. First, the fluorescein dye, where it appears green, and you can see in this fluorescent green under the cobalt blue filter. So remember this again, fluorescein dye we see under cobalt blue filter. Okay, and it is used in dry eyes to pick up the SPKs. There's multiple uses here. Corneal epithelial defect, which you can see, a corneal defect, as you can see in corneal ulcers or corneal abrasions. You can use the dye in apparition tonometry, which you see here. Apparition tonometry, these are rings which you have to stain with fluorescein, and Siedel's test. Siedel's test is for ruptured sclera. So when the sclera is ruptured, you push the eyeball like this, you can see the aqueous draining out, and this aqueous, because it's transparent, cannot normally be seen, but if you stain the tear film with fluorescein, you can see the clear pool of aqueous coming out to the ruptured cornea, which makes its way through the stained tear film. Okay, so multiple use of fluorescein dyes. The next important dye is for lissamine green, which you see the stained area of the conjunctiva in dry eyes. Remember, lissamine green stains the conjunctiva. Okay, unlike fluorescein, which stains the cornea, also in dry eyes, but fluorescein stain drains the corneal dryness, and lissamine stains the conjunctival dryness. The next thing is rose bengal, also conjunctival dryness. In rose bengal, you can see either rose bengal or you can use either lissamine green, though both of them can be used, but mostly we prefer the lissamine green because both of them stain the dry conjunctiva, but this is more painful because it causes a painful stinging sensation. So rose bengal is usually now is replaced with lissamine green because both of them stain the dry conjunctiva, in contrast to fluorescein, which stains the dry cornea. Okay. The next is a trypan blue. The last of the dyes is a trypan blue, which is a dye which stains for anterior capsule while performing the cataract surgery. When we do a capsular excisi, we have stained the anterior capsule with the blue dye. Otherwise, we cannot see the capsule at all because there is a mature cataract here. You cannot get the retroillumination which you gain in immature cataract. In mature cataracts, you cannot see the glow, so you have to stain the capsule in order to see it. This is the trypan blue stain. Then, and the last for all, ladies and gentlemen, this quick recap of the Guess the Paper series is a few important instruments of ophthalmology which were discussed in the app and in live classes. Just to summarize, recap, because I have a feeling that you will get a lot of these visual pictures this time in the exam. This is called the eye speculum, where you get a lid like this speculum which opens eye. When a various particular cataract surgeries or various procedures we have to perform, we have to keep the eye from blinking. The patient constantly blinking and closing the eyelid. We have to keep the eye closed. So this is a wire speculum. We can also have a universal speculum, basically keeps the lid open. So the patient cannot close the lid and obstruct our procedure. This is a wire speculum. Then the chalazion forceps, you recognize by the ring which grasps the chalazion here. And this is the chalazion forceps when we're doing incision and curettage. We do a curettage, not incident drainage, that is done for pus. This is INC, we do it here. So you will recognize the ring which grasps the chalazion here. This is not to be confused. Look at the ring here. It's not to be confused with a similar looking entropion clamp, where you will have a hook like this. One blade has hooked, the other is a solid blade, and you can see the clamp entropion. The lower lid is rolling inwards. Okay, so we have to operate this. It's called entropion clamp. Okay, so be careful about the entropion clamp. Do not confuse with chalazion forceps. The next thing is a punctum dial. Look at this sharp thing. It's a pointed thing, and we put it into the punctum. Whenever you are testing for the blockage, nasolacrimal duct blockage, we have to do syringing. So in order to put fluid here, BSS or water here into the inferior or the superior punctum, lower or the upper punctum, we have to dilate it with a punctum dilator, often called the Nettleship's punctum dilator. Just recognize this by its sharp tooth or the sharp pointed edge, which will dilate the lower or the upper punctum with. This is a punctum dilator. This is a foreign body spiral. Please recognize this. We take it out, we use it to extract the foreign body. So suppose you have a foreign body embedded in the cornea. So this is a very useful instrument. We just take it out like this, pull it out like this, called a foreign body spud. Can recognize this by its hook-like surface on the thing, which pulls often the metallic foreign bodies out, is a foreign body spud. Then this is a pinhole. You see this pinhole is a completely black plastic opaque disc. The central hole, the pinhole which you put in front of the eye, and the pinhole differentiates between optical error, loss of vision due to optical error or due to organic error, is it not? So when you put this pinhole in front of the eye, if the vision improves to 6/6 with the pinhole, then it's an optical error. If it does not improve, it remains 6/60 or whatever it is, then it's an organic error. Pinhole differentiates between optical error and the organic error. Very well. Placidose, just remember, look at this black and white ring like this. You must identify this. This is a very important instrument. So this is a black and white concentric rings, and through a central lens, we hold this in front of it, and you can see these rings get reflected from the cornea, is it not? From the cornea, and you can see what is happening to it. The rings, they will get reflected from the cornea, and if you see these concentric rings on the reflect from the cornea just as it is here, then it's a normal surface. But if you see these rings get distorted like this, they get distorted and they get crowded like this. Then it's the irregular surface of the cornea, and this is most likely a keratoconus. Remember, placidose disc is for identifying curvature problems of the cornea, curvature, surface curvature. So you hold this in front of your eye and the rings are reflected on the patient's cornea. Look at the reflection from the cornea. If they're irregular, Myers, it's keratoconus. If they're normal regular, they are normal discs. A very important instrument called the placidose disc. Ishihara's chart you should have no difficult identifying for testing for color vision. For color vision, is Ishihara's chart looks like that. So we have rapidly coming to now all the instruments all the basic instruments which you should recognize before the exam and in the exam too. A stenopic slit, ladies and gentlemen, again similar to a pinhole, except it is a rectangular slit in the completely opaque disc, which is stenopic slit, used for multiple reasons, particularly for Fmge's test, diagnosing the Fmge's test in you do it Fmge's test for differentiating colored halos of cataract and glaucoma. You can use it for producing the exact location of the optical iridectomy. So we have these multiple uses of stenopic slit. Okay, and this is very simple for all of you. I hope you've all done. This is the intraocular lens, monofocal intraocular lens that we use, the most common intraocular lens after cataract surgery that we use here. Intraocular lens you should all identify by the two haptics and the central optic. And the Maddox rods, look at these parallel glass cylinders, one vertical, one horizontal. These are Maddox rods for identifying phoreas at near. Okay, remember phoreas, we have Maddox wings for phoreas, detecting phoreas at distance, and Maddox rods for phoreas at near. This is the Maddox rods. We have to identify these by the pictures. And finally, gentlemen, it remains for me to thank you for a very patient hearing. I hope this has helped. This is all that you need. You have to go look at these pictures, identify these instruments, and may God bless you for your final exam on January 20th. Thank you very much and all the best.